So we are officially a day and a half into this conference, and the health equity, excitement and what we just heard in the last session was incredible. The activism, that it's been around, but we're ready to take action, right? No longer is it just words, we're ready for action. So I'm thrilled to be here. Thank you for joining us at this panel. My name is Nancy McCarrick. I am a senior health solutions consultant with Aon. And Aon is committed in this health equity space to leveraging data, using data in new ways to really close the equity gaps. And so I'm thrilled to be here to talk about that a little bit. So today we are sitting here with leaders from 3 innovation companies. And I guess I'll let each of you introduce yourself. I'll start with you, Charlotte.
Yeah. Hi, Nancy. Hello, everyone. Good afternoon. My name is Charlotte West. I lead the large market revenue team at Bind. If none of you have heard of Bind, or maybe some of you, hopefully some of you have, we get the most common question we get is Bind like an app? Is it a thing that lays over a health plan? I'm not really sure what Bind is. So to clear the air there, Bind is a health plan. And I'll be talking more about what Bind does as we go through the session today. But fundamentally, Bind has redesigned health insurance. And as we talk about health equity, insurance needs a redesign badly. There are just so many fundamental issues that are pervasive within insurance itself that need to be fixed in order to address the disparities that exist within the healthcare system. So Bind has completely redesigned health insurance, and we've redesigned it so that employers can offer better coverage at a lower cost to both employers and employees. If you're wondering how we do that, find me afterwards. We're not going to go into detail on that today. We're going to focus on health equity. But ultimately, we want to create a future where everyone can affordably get to their best health, and they can do so in a way that allows them to see their options, to see what treatments are available, what's covered, what isn't, and be able to make a choice that's right for them. So really Bind is about personalization. It's about creating cost and quality clarity in advance. And it's about truly offering an equitable, more inclusive benefit for all Americans.
Thank you. Tanya?
Good afternoon, everyone. I'm Tanya Dillard, as announced. I am the VP of Strategy and Innovation for Transcarent. And just to kind of give you guys an idea of how we think about health equity, well, first, we believe that everybody should have access to unbiased information, trusted guidance, and easy access to high-value care. And that is true of whether or not you are the janitor, whether you are in middle management, or whether you are the CEO. You should have access to all of those things so that you can have a great health and care experience no matter who you are and what you look like and where you come from. Now, how we get to that is the more interesting part, I think. It's what I spend my days thinking about in strategy and innovation and designing new solutions. We believe it really takes a commitment to an intentional design and the voices that are at the table and present going into thinking about new solutions, thinking about new experiences. Because the reality is as it has always been, but it's more increasingly so, we have a very diverse need for solutions in the marketplace. And if everybody sitting at the table designing those solutions looks the same, you probably have bias in your design. And so we take very, very seriously the design process, and we're really intentional about breaking down barriers in that process and all the solutions that we're bringing to market.
Great. Hello, everybody. I'm Elizabeth Dunphy, and I oversee the operations at Vitality Group. And really, we are a behavior change provider. Our core purpose has never changed. It's something we're very passionate about, and that's improving the health of members and people. It's at the core of everything that we do, and we are consistently looking at the data that we get in and trying to ensure that we have programs that meet people where they are. It's really our belief that we need to put the member at the center of all of the benefits that surround them, but really be there to guide them through so that they know what their resources are and that we're meeting them where they need those resources. So everybody has their own unique journey. Everybody is different, and we are able to see where people have risks, how they're engaging in our program, and really taking that and having strategic communication and nudges that really guide them and steer them to the care that they need to improve and to maintain their health.
You know, the last panel that was up here, it came across loud and clear that there's certainly bias in healthcare, we know that, but there's a lack of trust, and that was really underscored throughout this pandemic, right? So how are your organizations, and Tanya, I think I'm going to start with you on this because I heard the word unbiased a couple of times, and so how are your organizations, how are your programs and services really engendering trust?
This is going to sound cheeky, like I'm using semantics to be cute. The only way to engender trust is to be trustworthy. So that means for us, thinking about inclusive design. So whether it's time of day, location, language preferences, all of those things if somebody can engage in a way that those things have already been thought of, they are told in not so blatant terms whether or not they are welcome. And that starts to lay the pathway for trust. So that inclusive design is critically important. And again, it's hard to get there if you don't have diverse voices in the room helping to think about what the barriers might be to inclusivity. I would say then beyond that, we have a hybrid model. So, people have the ability to determine how they want to interact with us. Now, it could be in the digital realm, but it also could be picking up the phone and talking to one of our health guides. And those health guides are really instrumental in starting to build a relationship. And trust it's oftentimes relational in that it's the small things that start to build a pathway of trust. And so when you are entrusted with those small things, get that right, then you can be entrusted with the large things as well. And so we see health guides as a critical component to being able to engender trust.
And Charlotte, I mean, I know your model well, and I think about, some of the pitfalls of healthcare today where a claim doesn't get paid, it gets denied, all of the problems that we've all experienced. How does Bind engender trust in your program?
Yeah, when you're in a position to deny claims, it's hard to do that, right? But we can. We can, and we should, and we are. So someone can't trust in something or someone that they don't understand. So one of the first things that we're doing, and these things may seem small and simple, but they are so important. It is like the prior panelists who are up here, we have to find ways to take action. What is in our control that makes a difference, even if it feels small? So some of the things that Bind is doing is using really simple language, right? Over 90% of Americans can't define the terms that are pervasive within traditional health insurance. They don't know what the terms mean. We have to clean that up. We have to use simple terms that everyday people can understand. So instead of deductible and coinsurance, for example, that creates a lot of confusion, a lot of fuzzy math, a lot of uncertainty about, I need this care to get better, and I don't know what that's going to cost me from the organization that's supposed to be a financial protection for me. We have to do better there. So what Bind is doing is creating, instead of deductibles and coinsurance, those are gone. We have upfront prices, price tags. Everyone knows a price tag, right? You see it at the time of need, and then you know that's what you're going to pay. So Bind tells people that upfront. And then when they get the EOB, that's the amount that they pay. So what we tell them and the EOB have to match, that engenders trust. So simple language, simple experience, let's get rid of the jargon and confusing terminology that just keeps people in the dark. We have to get to a simple level, and many other industries have done this. Let's use everyday language that people can truly understand. And then, like you were saying, Tanya, I love this concept of to engender trust, you have to be trustworthy. We have to follow up on the commitments we make. And so having cost here match cost there, having simple answers to, is X covered? How many of you have tried to call your health insurance company and say, I need blah, 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 or I think I need blah, 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 blah? Is that covered? Getting a yes, no answer is near impossible. We are moving to yes, no answers. And those may sound simple, Nancy, but they are so critical to creating an experience that you can enable them to make confident decisions.
I mean, I see that every day with my daughters calling me about their health care. And they've lived with me all these years, and they cannot understand an explanation of benefits, an EOB, right? So we've got to be better at that for sure. So the barriers to care are very well established, right? You've got cost, you've got access, you've got bias. How are your organizations breaking those barriers down, not just for employers, because I think we, in this industry, think a lot about breaking down barriers for employers. We've got to break down those barriers for their members and their families. So, Elizabeth, I'll start with you. How are you doing that at Vitality?
So a lot of the things that, obviously we work very closely with employers to understand what their needs are and the needs of their populations are, and really trying to ensure that we can help them serve those populations. So one of the things that HR teams are struggling with right now is there's so many great tools out there that they want to bring to their diverse populations and their needs, but they can't afford them all. They just don't have the budget, and they really are faced with, they've got 10 needs that are across their population, but they can only pick one partner because of the cost that's associated with it. And so what they're struggling with is they know that there's a whole population that's not being served. So what we've done with our ecosystem is we have created a way that the client and employer can do a contract, sign one contract with us. We bring in all of our partners, and we then, again, put the member in the middle of that. So the member now has that choice, but we're there to help guide them. We know choice can be confusing, but we're guiding them along the way, and we're really making sure that we're taking all of the information we have on their risks, the way that they're engaging in the program, and we're directing them to the care they need. What's great about it for the employer is the employer isn't, having procurement teams that are going out and finding partners. They're not having to make sure that they're vetting partners. We've done all of that for them. But the best piece of it is they're only paying for their members that are using certain resources. So instead of paying across the board, it's based on the service that's being provided to that member. So it really does open up that access and makes it seamless for the members to be able to get into that.
Yeah, and what I'm hearing from you too is this idea of a platform, right? And a platform, which there's more and more platforms are being developed to help streamline the process you're talking about for employers, but it also serves as that on-ramp for the employee, so that they have one place to come. And I think, Tanya, you're doing some work in that space to help the member once they go up that on-ramp with this longitudinal look of care. So do you want to talk a little bit about that?
Oh gosh, sure. So we do have what we would call the digital front door to be able to bring people in an on-ramp. Also, people can pick up the phone and call and talk to one of our awesome health guides. But yeah, so, sorry, can you repeat the question?
Yeah, it just, when we were talking about the barriers to care, part of it is getting there and making the process simple, so.
Yeah, so once somebody has said, I need care, right? And the way that we think about it is what are the access barriers? What are the cost barriers? So we really are intentional in design around that. So one of the ways that we get around the cost barrier is to lead with value-based care. So our contractual arrangements are almost all value-based care, risk-based, and are pretty, what I would say, predictable for the employer. So a really good example of this is our surgical centers of excellence, for example. We are able to contract with providers in such a way, in a bundled arrangement, if you will, that we are able to offer services at such a decrease in cost that then the employer can turn around and offer these services at no out-of-pocket for their employees. So that's one way that we get around the cost component. And then the access component, again, it shouldn't matter what time of day you need services. In fact, when we have healthcare needs, it's not a 9 to 4 or 9 to 5 kind of endeavor. And so whatever time of day, wherever you are, we make accessing a doctor as easy as click to chat. In 60 seconds, you can reach a physician 24 hours a day, 7 days a week. So those are just two examples of the ways that once you come into our front door, whether it's the digital or the telephone, we're able to work with you, get you the care that you need, and reduce the barriers at the same time.
Yeah, I like that you mentioned value-based care too, because we heard in the last panel that that's how you create the business case for equity when you start to think about equity and value-based models, and everybody's in it together. So I like that, how you frame that. There was a recent Deloitte CEO study where 94% of CEOs said that DEI is a personal strategic objective or goal. And so I'd like to know from you all, what are you hearing from your clients about infusing diversity, equity, inclusion into their benefits? We heard about how, infusing it into health, but how are we, as benefit practitioners, how are we infusing DE&I, and what are your clients asking of you? Charlotte, I'll start with you.
Okay. Yeah, so DE&I initiatives are certainly not new, right? I mean, there's a lot of work that's been done over many years to move the needle on DE&I. And so in some ways, what we're hearing from our customers is that that's table stakes, right? Like that's an expectation that we have of all of our partners and of ourselves. What we've seen expand a bit is that those DE&I initiatives are kind of spreading out within the organization, and HR teams are being expected to articulate and design total rewards and benefit strategies that support the broader DE&I initiatives. So going back to, okay, what action can we take? What can we meaningfully do to make that happen? And so what we're hearing from our customers, in particular our large employer customers, is that they need to make care more personalized. They have these massive workforces with really, really diverse needs. They need a platform on which they can create a more personalized experience. What we're also hearing is that they need to increase access to virtual care, in particular in light of the pandemic and all the mental health needs that go with that. So one of the really interesting things that we've seen is that access to virtual care within Bind, and we tee it up in the moment of need, so someone doesn't have to go search in some other platform to figure out, oh, I can access a virtual provider here. We have seen our use of virtual care be 3.5 times the average that Doctor on Demand, our partner, typically sees for their other health plan partners. So when you create an easy access, that can move the needle significantly. The other thing that we're hearing is that just by virtue of offering Bind itself, that is moving the needle for our customers on creating a more inclusive, equitable benefit. So going back to the deductible examples, deductibles are inherently unequal. Not everyone can equally afford what I think the average is now over $1,600 deductible. 40% of Americans can't afford a $400 expense, much less a $1,600 one. So creating an environment of first dollar coverage is so critical. The other thing that I'm just so proud of Bind for doing, and we've gotten just enormously positive feedback from the market on this, is that we have used both claims data and clinical evidence in order to identify those conditions that disproportionately impact disadvantaged populations. So specifically the BIPOC population. So things like maternity, things like newborn care, things like diabetes, things like sickle cell, dermatology, like we were saying. So we've identified those conditions. We've then identified the treatments for those conditions. And because of the personalized nature of Bind's model, we can actually reduce the copay, the member cost, for the treatments for those conditions. We actually had one of our customers share with us, when we shared with him that they had the option to do this, he actually got somewhat emotional about it and said that he grew up in a family where his father was a pediatrician who mostly cared for disadvantaged populations. And the care the condition of the children that would come into his office, having been treated in other areas, was so, there was so much inequity that he was beyond thrilled that he could offer now a benefit to his people that actually targeted more coverage, easier access, lower cost for those things that these populations have for decades been disadvantaged.
That's great. I do want to check in on our timer. I'm not sure how we're stacking up for time, but it didn't go.
I'd say 10:15.
Okay, thank you very much. So Elizabeth, do you want to jump in on that one too?
Sure. So what we've been doing is we're working with our clients to really understand what they're doing with their population. So we have a client in particular that is really digging into the social determinants of health of their population and have identified some really key things. So the last panel talked about the literacy as well, and we've talked about it here. People just don't understand their benefits or how to access their benefits. There's also the financial crisis that they're under, as well as transportation to and from getting medical care. So we're working with them in ways to better understand how we can change their communication strategy to ensure that it is clearer and we can really nudge and direct those people to the right care. Some of the things that they're doing is they're implementing more financial partners to help work with this population. And we are taking what our benefits are and we're segmenting them for certain populations where they might need greater interventions. So the work that we're doing with them is more so about the communications and the nudges around that. One of the other things that they're doing is they found in their big distribution centers that people just can't get to the services that they need, so they're bringing the services to them. So they're implementing some pilot mobile programs that are actually going to go right to the distribution centers to treat the members there. So there are a lot of different things, but most of it is really understanding and meeting with their population to understand what the needs are and what they want. And that's how you're probably seeing some of the changes you're seeing in the requirement for benefits is they don't understand them. They're not utilizing them. They are going to the emergency room and having these high cost incidents because they don't understand it. And it's more about the communication of how we can help them understand and guide them in the right ways.
Yeah, it's really fascinating. Again, not a new subject, but we're looking at data in new ways. And I know at Ann, we're looking at geography, where people live and what the health deprivation index is, right? So are there pockets, you can look at Boston and narrow it down and come up with geographies within the city that people don't have the right access or the right quality, even in a city like this. So I do love that use of data. So the pandemic has exacerbated mental health. There's this crisis that was already here. It's gotten worse. Share with me a little bit about how you were looking at mental health when you're thinking about the delivery of care to the members you serve. Charlotte, do you want to start on that one?
Yeah, I was mentioning a few minutes ago, we saw the use of virtual care not only increase during the pandemic, but we saw a huge volume of folks accessing virtual care through Bind relative to some benchmarks. And I think the reason for that is really twofold. One is that when you put something in the natural path that someone is already taking in the moment of need, it's not in some enrollment brochure that they got during open enrollment, whenever. It's not on some website that they don't really know where to go. It's right there in the moment that they're understanding what's covered, what is it going to cost me, what are my options. So I think that's number one. If you put it in the natural path, the workflow, it's just easy. It's like the easy button, right? So that's number one. Number two is that we embedded mental health into the solution set that's available through virtual care. And interestingly, 4 out of the top 5 reasons for care during the pandemic, all mental health. So there are additional resources that are available to our customers. Some employers have additional resources available through their own organization. We can, again, with this notion of make it easy for people, put access to information right in the hands when they need it. We can embed those solutions within the Bind experience as well. It doesn't have to come from Bind, it can come from the employer. And so that has made it a lot easier for employers to say, hey, we're trying to help you. Look at these, there are all these resources available. Just getting, especially in the pandemic when everyone was scattered, communication was very difficult. It just puts it in that natural workflow and makes it a lot easier for people to see what resources are available to me, what makes sense for me in my personal situation, and make it really easy for me to just go and access it.
That's great. And so I think in the interest of time, I'm going to go to my last question here, which is, and we've heard this throughout the day and a half, there's no silver bullet. We want to move from aspiration to action. What is one action that your organization has either just recently taken or is about to take that will affect a specific population? So Elizabeth, do you want to start with that one?
Sure. So we are actually in the process of ensuring that diversity, equity, and inclusion is really in our entire program. All of the enhancements that we're doing to the program, making sure that our communications, our visuals, we heard a lot about if they don't see it, if they can't touch it, if they don't see themselves in it, they don't feel that they can be part of it. So we have a real focus around that, and also ensuring that we're addressing the mental health and needs of populations and understanding what is it that they need, what can we do, and what can we bring to help them with the resources that we have.
Thank you. Tanya?
So our partnership with Walmart was recently announced. So this is going to enable us to bring low-cost medications to our entire member base and to everybody else that we continue to contract with. So we're very excited about that. And so, of course, knocking down that cost barrier, of course, is hugely important. I can give you other examples, so that's a big one and a pretty simple one. I would also say, when we think about, a really good example is our Surgical Centers of Excellence program. So what we think about is being able to affect people's health no matter what zip code they come from, right? So, there's the adage, and I come from public health, that where whatever your zip code is determines your health status. And really with our Surgical Centers of Excellence program, that's not the case anymore. That we can look at a high quality provider that's potentially in your area, or we can travel you, and we have an incredibly great outcomes that come out of our Alaska population, where we have been able to travel people for surgery to centers of excellence that they ordinarily wouldn't be able to access. and that wouldn't be available to them in Alaska. So that's just one of the ways that we're actually furthering the cause of high quality care, no matter where you live.
That's great.
So that's 2, sorry.
That's okay. Charlotte.
Yeah, I may have 2 also, I don't know. So the first thing I'll mention that, again, I'm so proud of Bind for doing is, and this notion of value-based care that one of you mentioned earlier. I explained that Bind doesn't have deductibles and co-insurance, rather we have price tags. Those price tags or copays vary based on the underlying cost, quality, and efficiency of that provider. So what that means is that if something is of higher value and has been proven to be effective and efficient in delivering care, it's going to cost the member less. That price tag is going to be lower, and in some cases, it's going to be significantly lower. And cost isn't everything. This health equity is a multi-layered problem. There's no doubt about it. But again, what action can we take? And the action Bind can take is to lower cost and increase access where we know there are disparities. So that's number one. And then related to that, we know that there are these conditions, like I mentioned earlier, that have historically, they have disproportionately impacted disadvantaged populations. What can we do about it? We can make those lower costs because we have a personalized plan design. Again, we've re-engineered insurance design so that we can do that. We can say, you know what, if you have diabetes, or if you have sickle cell anemia, or if you have a NICU baby, your costs are going to be lower. And we've actually seen that the overall cost to the plan is minimal, like less than 0.5%. But to be able to reinvest those dollars and direct coverage towards these areas of need, and where there's been just so much disparity in the past is really important. We have the data to do it, we have the technology to do it, and Bind is doing it.
Well, thank you. You know, I appreciate all 3 of you and your organizations, and I know that your the organizations you work for are helping employers take bold action in support of reducing inequities. So we weren't planning to take questions, but I know all of you, I'm sure, would love to speak to anyone that has any questions, as would I. And thank you all for joining us today.